All right, so today we're going to be talking about Wolff Parkinson White. This gave me a lot of confusion when I was a student as well as a resident, so I wanted to kind of clarify some of the pathogenesis of it, some of the arrhythmias you can get from it, as well as the treatment subsequently for Wolff Parkinson White syndrome. Let's start off. What is Wolff Parkinson White syndrome? So these patients will have some sort of a bypass track. All right, so what is a bypass track? It's a way really to get from your atria and get into your ventricles. So in a normal patient, what happens is that you get, starting at the SA node, you get conduction to your atria. That gives you your P wave. That goes to the AV node, and then you have a delay in the AV node, and then subsequently goes into your His-Purkinje system down to your ventricles, creating your normal QRS, narrow QRS complex. But how is this messed up in patients that may have Wolff Parkinson White syndrome? Well, these patients have a bypass track. Some of these patients, it may be present on just a normal EKG. Now, instead of having that typical P wave and then a delay and then that QRS complex, these patients will just go right from their P wave here, which is that atrial contraction. But then you'll kind of have slurring of that P wave down into the ventricle and subsequently a little bit of a wider QRS complex here. You have that slurring because you don't have that AV delay from here to here, and then you have basically a little bit of a wider QRS complex because you have loss of normal His-Purkinje system efficient conduction in your ventricles. Now, there is a difference of Wolff Parkinson White pattern. This is patients that have this pattern, but they don't have arrhythmias secondary to it. A lot of times, maybe at higher rates, this bypass tract shuts off. They're not able to really get conduction through the bypass tract, so they never get at a high risk for arrhythmia. But in Wolff Parkinson White syndrome, people have that EKG finding, and they have symptomatic arrhythmia. You can do EKG studies, EP studies in patients that are high risk to see if you can develop arrhythmias, see if they can have high rate of conduction to that bypass tract, which subsequently will help treatment for these patients. Some patients also may have a concealed bypass tract, which means that it can only go retrograde and can't go anterograde. Because it can only go retrograde, it will never create the Wolff Parkinson White pattern on EKG because it's just really not able to go this way. So some people can have it concealed where you will not see it on an EKG, but they can still get retrograde conduction, and really these patients can only get orthodromic AVRT. So what is orthodromic AVRT? So this is going to be our first one. So orthodromic AVRT starts off with normal conduction. Patients will go through the AV node. They'll go down the His-Purkinje system both ways, creating a very narrow complex. Problem with is these patients will go back up into your atria, back to your AV node again, and cause this reentrant arrhythmia. There's some ways you can tell that this is AVRT instead of AVNRT. AVNRT is basically conduction within the AV node itself, so the P wave comes right after the QRS. But for AVRT, it takes a little bit to get down the ventricle and back up to your bypass tract. So as you can kind of see here, here's your QRS, normal, narrow QRS, and here's your P wave a little bit further after it. It's not buried in the QRS, it's right after QRS. It takes a little bit to get down those ventricles and back up and back through that bypass tract. Now, you can kind of see in this reentrant tachyarrhythmia, it does conduct through the AV node. So anytime you do have someone that's in narrow complex tachycardia and they're unstable, it's easy. Your job is pretty much done for you. You know you got to treat them with electricity. You have to cardioverse. If the patient is stable, for these patients, you can actually start with vagal maneuvers. And, these patients will still respond to adenosine. So follow your ACLS algorithm, start with the vagal maneuvers. They're savers to consider adenosine for these patients. Adenosine is going to block that AV node. Since the reentrant loop is through the AV node, this will stop that arrhythmia from continuing to happen. And like most treatment, for these patients, chronic treatment is going to be ablation. You really got to take out that reentrant pathway to prevent recurrence of this over and over again. All right, so now we get to the harder ones. So that's orthodromic AV-RT. Remember, it goes down normal pathway through the AV node, comes normal conduction, synergistic conduction down the His-Purkinje system, so it creates a narrow complex back up to the atria, and subsequently creates a re-entrant loop. If unstable, cardioverter is stable, you may want to use adenosine. Here's your harder ones. So let's go to antidromic AVRT and pre-excitation, AFib, and aflutter. So what's going on with this? So antidromic AVRT is not going the correct way. It's going actually from the AV node, it's going through that bypass track, and then you're having myocyte to myocyte conduction through your ventricles, which is going to be inefficient conduction, and it's going to give you this wide complex tachycardia that you see here. It's very wide because it's not going down the His-Purkinje system. It's going to be very inefficient. It's just myocyte to myocyte conduction, which is very slow, which is why you're going to give QRS. Any wide QRS means that there's slow myocyte to myocyte conduction for some way, shape, or purpose. Then goes back up into your atria and causes this reentrant loop. Acute treatment, anytime you have a wide complex tachycardia that is unstable, is going to be cardiovert if unstable. And then for people who are stable, you're going to actually do something, give these patients usually procainamide. So that is your antiarrhythmic to go to, is going to be procainamide for stable patients, cardiovert for unstable patients. Anytime someone's unstable with a wide complex tachycardia, you are going to cardiovert them, you're going to use some sort of electricity, so pretty easy. This is cut off a little bit here, but chronic treatment is going to be the same. For really any of these, you really got to take out that bypass track, which is going to be an ablation. Right? So that's antidromic AVRT. For this one, this is when you really, really need to avoid AV blockers. And someone that has this, avoid AV blockers in the future for these patients. Avoid things like beta blockers, avoid things like calcium channel blockers, digoxin, amiodarone. And the reason why is that the problem is that the more you block this AV node, the more their conduction wants to go down the bypass track, and the more that you can actually precipitate arrhythmias. So these are the patients that you avoid those AV blockers. You also avoid AV blockers in patients with pre-excitation, AFib, and aflutter. And this can be one of the more dangerous manifestations of Wolff Parkinson White. So what's happening with these patients? They have a bypass track, and they have a bypass track that can conduct at high rates. These patients, for some reason or another, it being one of the most common arrhythmia, they get atrial fibrillation. Atrial fibrillation is going extremely fast. It's going sometimes above 300 from all these ectopic and aberrant loci of electrical impulse in atria, and these are going down this bypass track and creating a very, very fast, irregular, wide complex tachycardia that can go up to 300. This can cause ischemia secondary to decreased diastolic filling, because you have decreased diastolic filling time with a tachyarrhythmia, which can generate the defib and cause sudden cardiac death. Just like unstable antidromic AVRT, it's pretty easy. If they're unstable, you cardiovert them. Most of these patients are going to be unstable. I guess if they're stable, you can do procainamide as well, but most of the time, if you see this they may be going at 300. The patient is unstable, or they're going to become unstable. You need to cardiovert. Once again, avoid AV blockers. AV blockers will decrease normal AV conduction and put you at higher risk of developing this arrhythmia and developing an aberrant arrhythmia going down the bypass track. And once again, AFib, this is going to be wide complex because it is not going through the His-Purkinje system. It's going myocyte to myocyte conduction, very fast, irregular, wide complex tachycardia. You do see this cardiovert. If the patient has antidromic AVRT or they have pre-excitation, AFib, aflutter, you do really want to avoid those AV blockers. And reality for these patients, as always, to prevent this from occurring again, you're going to need ablation. for chronic treatment, for chronic prevention. All right, so those are all the reports in light. I always felt that it was difficult differentiating orthodromic AVRT, antidromic AVRT, pre-excitation, AFib, and aflutter. Orthodromic AVRT, and remember, just like AVNRT, you can use vagal maneuvers and adenosine if the patient's stable. You can cardiovert them unstable, and chronic treatment is going to be ablation. These patients, you don't have to worry as much about beta blockers, AV nodal blockers, because they still are actually going through the AV node, and they're having retrograde conduction. But antidromic, pre-excitation, AFib, aflutter, you really want to avoid any AV blockers for those patients in the future. And you want to really ablate, for all of these patients, anyone with a symptomatic arrhythmia, ablate that bypass tract to help it prevent it in the future. All right, that's all I have. Thanks for joining.